For session 10, we want to look at assessment and resuscitation of the newborn. This session will introduce students to the assessment and resuscitation of the newborn after delivery. We'll be doing assessment of the newborn, which will involve a detailed and systematic examination of the newborn immediately following delivery. About 5 to 10% of all newborns need some resuscitation at birth, and as a result of failure to initiate and sustain respiration at birth. The newborn, it's important that you assist the newborn to initiate and sustain respiration, and the resuscitative measures include thorough drying of the baby, providing warmth, stimulation, external cardiac compression or massage, which is debatable of late, and the use of medications. At the end of the session, you are expected to be able to provide immediate care of the newborn, perform resuscitation on the newborn with asphyxia, and perform physical examination of the newborn from head to toe. The key topics to be covered in this session are as follows: purpose of neonatal assessment and resuscitation, neonatal assessment, neonatal resuscitation, and the resuscitation. We're looking at the bag and mask ventilation. We're talking about a little bit about chest compression. That's the reading list. There are others in the reference list that you can also use. We want to start with our neonatal assessment. Why is it important to assess the neonates? Assessment of the newborn at birth forms the basis upon which further decision making regarding the baby is made. During assessment, abnormalities that are present on the newborn are detected and interventions instituted as soon as necessary. Now, it's important that we examine this newborn as early as possible so that we can also obtain a baseline data, and then if there are any deviations, we can intervene before complications. We also want to determine normal functioning of the neonates. We'll be looking at all the different body systems, and then for healthy adaptation to extrauterine life. We know that in intrauterine life, the placenta plays a very major role for this baby, and it supplies the fetus with nutrients, respiration, and all that. Now, when the baby is born, it is important that it's able to adapt to extrauterine life. That is life outside the uterus. This baby should be able to establish its own respiration and sustain the respiration. Neonatal assessment will also enable us to detect any deviations that necessitate immediate management. We also detect any congenital problems present in the neonates so that we'll be able to advise or support the parents before she gets access to this baby. Now, before you do assessment is not an emergency. So before you do assessment, it's important that the baby is stabilized or respiration is established before you go on to do assessment. If for any reason the color of the baby is bluish or there are signs of asphyxia, we may have to stabilize the baby before we proceed to do the assessment. And the assessment should be performed under aseptic condition. Remember that this baby was in a sterile environment in the mother's uterus and is now coming out, and it is important that we are able to maintain some level of infection control. And the essence is that the baby is yet to build immunity against infections. So any infection we introduce to this baby very early, the baby will not have that immunity to fight against it, and the baby is prone to infection. The assessment should be systematic. It should follow from head to toe, and you should use the systems approach for complete examination. Remember that we want to examine this baby, but the warmth must be provided throughout the assessment. If this baby loses heat, the baby is going to have hypothermia, and all the vital organs in the baby will be depressed, including the brain, the liver, and all other vital organs. So then we want to assess and look at the baby. We are coming from head to toe, so we do it in bits, covering the baby halfway so that we provide some level of warmth. Also remember to ensure safety. If you are measuring the baby, you want to lift the baby, make sure that the baby surrounding is clear from anything that can injure the baby. You don't keep scissors and other sharps on the baby's cots or the table where you're examining the baby. No hot materials around. and then make sure the baby cannot fall over the area of examination. It shouldn't be slippery. The surface should be firm. Examination must also be carried out in the presence of the mother, or if for any reason the mother cannot be so close to the baby, it should be within the mother's view, where she can also be looking at exactly what you are doing to the baby. If you want to do assessment of the newborn, these are some of the things you will need. Measuring tape. You want to measure the various circumferences from the head. Some measure abdominal girth, though it's not routine. You want to measure the length, the chest circumference. So it's important that you get a measuring tape on your tray. And then you need a weighing scale. You also need good light source. You need gallipot with sterile cotton wool. You need cord ligatures in case you want to tie the cord, or sometimes if secure the cord but it is bleeding and you may have to reinforce the ligatures. And then you need a thermometer and a pulse oximeter. Now you can start with the measurements. Some will also prefer to finish the assessment and then they come back to finish up with the measurements. Whichever way you do it is acceptable. So you're looking at a head circumference. Very soon we're looking at how practically we are going to place the tape to measure the head circumference. But you should, as you're doing this examination, it is important that you draw on your anatomy. You should remember the normal newborn. You should remember the physiology of the newborn. You should be able to know the normal measurements, so that immediately you meet an abnormal measurement, you'll be able to detect it and then intervene. So the head circumference should be around 33-35 centimeters. If for any reason this head is abnormally small or abnormally big, then it tells you that there may be some congenital abnormality. You also measure the chest circumference, which is also close to that of the head, around 30 to 33 centimeters, and then the crown to the length, to the heel, which is the length of the baby, measuring 48 to 52 centimeters. Most babies around 50 centimeters. You should also look at the temperature of the baby, the pulse and the respiration, and then you also measure the weight. Now I want to look at the procedure. You have to wash your hands properly. Remember, we are saying that we need some level of sterility because the baby has come from a very sterile environment, and then we don't want to infect this baby. So you wash your hands very well, you dry them, and then you wear sterile gloves. You uncover the baby and note the general appearance of the baby. Your findings for a normal baby may include the body contour, which is cylindrical and symmetrical, the hair, which is large in proportion to the body. This baby has a narrow chest, protruding abdomen, and small hips. And these are all normal for all newborns. So this is the general look of the newborn. You assess the baby's skin. When you are assessing the skin, you want to know the color of the skin, especially around the mouth and the fingernails or the nail beds. Because if this baby is having a problem with oxygenation, then those centers are going to be discolored. So once you do the skin assessment, you have to check for this. You note any vascular nervi, you note Mongolian spots or trauma marks on the head, the neck, or the body, especially if it is an assisted delivery or cesarean section, sometimes, or forceps delivery or vacuum extraction. You should look at, as you look at the skin, you may find if there was some trauma on the baby. Just looking at the skin, you may find this trauma. Now you start from the head. You assess the head for symmetry. So if you put the baby down, you should find that the head is in the center, and then you look for caput. You look for caput ocidanium or cephal hematoma. You want to look at the status of the sutures and the fontanelles. They shouldn't be bulging, they shouldn't be sunken. You assess the face of the baby. You observe for symmetry of the face. The baby should not be having palsy. If the baby is having palsy, you realize that one side of the face will be drooping. If there is no palsy, then you find symmetry. You note any characteristic feature like flattened nose, any folds below the eyes. So you come to the eyes. You examine the baby's eyes for response to light. You look at any puffiness in the eyes. Some may be discharging at birth. Maybe they have some infection in utero. And then you can look at opacity of conjunctiva, and then whether there's any hemorrhage or blood shots on the eyes. Now you assess the nose. In the nose, you are looking at the appearance of the nose. How is the baby breathing? Is there any flaring of the nostrils? What is the septum of the nose like? Is there any symmetry? Then you assess the ears. For the ears, you want to touch the cartilage and see if it is firm. Is the presence of ear canal? Is there an opening in the ear? The location on the head. Where is the ears set on the head? And it is very important because it denotes a lot of chromosomal abnormalities. We know that the penis should be at the level of the contours of the eye. If the ear is low set, it means that the baby is having a congenital abnormality. And then you look at the hearing of this baby. You assess the mouth of the baby. When you examine the mouth, you want to find out, is there any cleft lip or cleft palate? Is there any asymmetry when baby is crying? Is she having natal teeth? Some babies are born with false teeth. You also look for macroglossia and pooling of saliva. Now you continue to assess the neck. You examine whether the head is freely movable. In a newborn, some level of lagging of the head is acceptable, but you should be able to identify between the normal and the abnormal. You check for the neck, whether it is webbed on the shoulders, and then you extend the arms on one side, tightness of muscles on one side. So as you are assessing the neck, you make sure that you are looking out for all these things. Sometimes in the webbed neck, you may have some growths or some lymph nodes. So you make sure that if the baby's neck is very small, you extend it to find out within the folds if there are any growths in the folds. Now you assess the chest of the baby. You examine for the shape and movements when the baby is breathing. What is the respiration pattern like? Remember that in the normal physiology of the newborn, some degree of apnea is tolerated or acceptable, but then it shouldn't be too much. And then grunting sound on expiration should be watched out for. Look for retractions on expiration, the heart rate, the clavicles palpable on both sides, and the presence of breast engorgement and secretion of milk in the newborn. Now remember that if the baby had a fractured clavicle, when you're looking at the chest, the clavicle may be swollen, or you can find a depression when the bone is gone down. So you observe for all these things and rule out any abnormalities. Now you come to the abdomen. You note the shape of the abdomen. Remember, we have said that some abdominal protrusion at birth is normal. You look at the umbilical cord stamp for presence of the 3 vessels. Is there any mass on the abdomen? Are there bowel sounds? Has the baby passed meconium? Sometimes you can find some big veins on the abdomen and it's highly extended and shiny, and all those things are abnormalities. Now you want to examine the genitalia. If it is a male, then you pull the foreskin, and that covers the glans penis. You should, if it's a male and it is normal, you should be able to pull the foreskin. It shouldn't be tight or adhered to the glans penis. Now, urethral meatus opens at the tip of the penis, so it should be in the center. Sometimes you can have what we call the hypospadias or the epispadias, and you have to check this. Testicles are palpable in the scrotum bilaterally. You should find both testicles present at birth. If any is not descended yet, which is very common in preterms, then you note it. In the female, you want to look at the labia minora. It's prominent and it's not covered by labia majora at birth. And then you have to look at edematous genitalia. Now, if the baby was born in breech presentation, it is common to find some edematous genitalia, maybe due to the examining fingers going into the vulva all the time. And then is there any vaginal discharge? Or sometimes the babies can be born with what we call pseudo-menstruation. Pseudo-menstruation, you may find bleeding in the vagina, and it results from a withdrawal of the female hormones. Now you assess the back. You hold the newborn prone and examine the back to evaluate the spine. You note, so you can run your 2 fingers along the spine, and then you know the presence of any dimple in the coccygeal or sacrococcygeal region, any sinus opening or spinal bifida, any tufts of hair along the spine. And all these things are signs of abnormality. Now you assess the anus. You verify the presence of a perfect anus by inserting a soft rubber catheter gently into the rectum. Or if the newborn has passed meconium, there is no need to do any such assessment. The patency of the rectum must be checked. Remember that it should be something very soft. If you put in any hard substance in the rectum at this stage, the baby may begin to bleed. So now some are even talking about the fact that it is not important to assess the patency of the rectum, and just ask for meconium, and then you'll be able to identify whether it is patent or not. You assess the upper extremities. You note the proportions to the rest of the body. You note the symmetry. You put the hands beside the baby and see if the length is the same, the size is the same, any spontaneous movement of the arms and hands. So here you want to check if the baby having any twitching. You check if the baby holds hands in fists. Fingers show webbing. So you have to open the fingers and check in between the fingers to see if it is webbing. And then you check for polydactylism or syndactylism. Is the baby having any extra divots? You count the number of fingers and check if there is any extra divots. Sometimes they appear as very small in between or just besides it, and they may not have any bone, but you may see that there is an extra structure apart from the 5 fingers. And then the fingernails, you check if they are developed and extend beyond the fingertips. If any skin tags are present, you note all this. You assess the lower extremities. You check the legs for the following: for the symmetry and the length. So you put the legs together and you check if they are of the same length, and you check if they are also of the same size. Then you look at the range of motion. Can the baby's thigh or hip be moved? Can you move the legs to abduction, extension, and all the other range of motion without any pain or any crackles? If there are crackles, it tells you the baby had a fracture. Or if the baby pulls away, you know that there is some pain. Proportion to the rest of the body, the symmetry of creases of legs and buttocks. Remember that the crease in the lower extremities are also significant, just as the creases in the upper extremities, because they can also denote any congenital abnormality. If you pick children with trisomy 21, you can examine even from their palms or from their feet, and the creases will tell you that there are some abnormalities. With the knees flexed, you abduct the legs to the table in frog-like position, and here you want to check whether there is any pain or any fracture and the range of motion, like we said earlier on. Assess if the legs are persistently limp. So you lift the leg and you try to put it down. If it drops from your hand immediately, then there could be some paralysis, or we say the leg is limp, and you do it for both legs. You assess the feet, examine the soles for the presence of wrinkles. You also want to look for webbing and polydactylism or syndactylism. You assess cardiovascular system after making the baby quiet, auscultate the heart sounds, and feel for pulses in the upper and lower extremities. Now you also perform neurological examination. Here you are eliciting for reflexes, and it tells you how the nervous system is working. You have done this already, so I've just mentioned them. You look for the moral or embracing reflex. You look for the rooting reflex, and then also for the sucking and swallowing reflex. There are other reflexes like the palmar grasp reflex, the plantar grasp reflex, and the Babinski reflex. We have said that the head may lag, and you grab the infant's hands and arms and gently pull the infant to a certain up position. If head lag persists beyond months of age, it signifies neurological complications. Inform the mother about the baby's condition and well-being. Record the findings in the newborn assessment and record. Now there are some dilemmas. For instance, if you examine and you see gross abnormalities on this fetus, some are asking what is the best time to tell the mother. Is it immediately? Do you wait after some time? And how do you break this news to the mother? Should it be in the presence of a support person or significant other, such as the baby's father? Or how do you go about breaking that news? This brings us to the end of our neonatal assessment. There are other things you can do. And then from here, we'll be looking at neonatal resuscitation procedures.
This is general head-to-toe examination of the newborn. You begin by washing your hands and wearing a sterile glove. So I've assumed I've washed my hands and I'm in my sterile gloves. You expose your baby. Then you remove the head, the cap, and then any other dressing you have on the baby. So you quickly do a general observation. You look at the muscle tone and the movements of the baby. You look at the color and then anything you can observe on the baby. So you quickly examine the head first. You look at the fontanelles. If there's any bulging or sunken fontanelle, you observe the sutures by running your hands around. For any overlapping, it is normal. You come to the face, you examine the eye for any discharge and then alignment. You come to the ears. Are they well aligned with the eye? If they are not aligned, it denotes a chromosomal abnormality. Everything is fine. You check the nose for patency. For the septum, if there's any septal defects, you check the mouth. You open the mouth for any false teeth. You look at the tongue for any enlargements, any accumulation of saliva in there. And then you come to the neck for any webbing. There's no webbing. And then you come to the upper extremities. You align them to see if they are equal. You flex and see if the tone is okay. You come to the chest, you observe the breathing. That's the rise and fall of the chest. And then you come to the abdomen. You look for any distension of the abdomen by palpating or observation. And then you check the cord. If you can't see clearly, you can pick a cotton wool swab and then you clean the tip of the cord. And you look for any bleeding or discharge and check if you can see your 2 arteries and 1 vein. It is fine, then you can quickly discard into your receiver. You come to the genitalia. For males, you look for descended testes, and then for the penis, you pull back the foreskin, and then you look for the urethral orifice and observe for any episphagia or hyposphagia. Everything is normal in our baby. For females, you check for the labia majora and the minora to make sure that the majora is not covering or infused into the minora. You check for any discharge or pseudomenses. Then you quickly come to the lower abdomen. You as well check for the alignment and see if the length is equal. You flex the knees and see if they are flexing very well, if the tone is okay, or any fracture of the limbs. Everything is fine. You quickly go back and run your hands on the spine. You observe the sacral region for any spider bifida, any dentation, or any dense hair around there, which can give you a clue for a chromosomal abnormality. So after running your hands or checking the back, you observe for the patency of the anus. Our baby has already passed meconium, so we assume that the anus is patent. But if your baby didn't pass meconium, then you quickly use a rubber tubing, very flexible and small rubber tubing, and pass it through there. Some people use the old mercury thermometer to check it, to see if it's patent, but you have to do it gently and quickly so you don't traumatize the baby's anus. Now we come back and check the head circumference or other measurements of the baby. So you pick your tape measure. For the head circumference, you measure from the frontal area round to the occiput and back. And we said that the normal measurement is 33 to 35 centimeters. Then you come to, for the full length, you measure from the occiput, come down to the sole of the feet, and it should be 50 to 52 centimeters. So everything about our baby is fine. Then you do cord dressing and continue with routine care. You dress up your baby. You cover the head with a cap. And then you pick a new cord sheet, because this one might probably be wet. Remove this one, and then you quickly wrap your baby in a new cord sheet to prevent hypothermia. So that is for general head to toe examination of the baby. After covering the baby and keeping the baby warm, you now hand over the baby to the mother and explain and tell her the findings. And if there's any abnormality, you let her know. If there's no abnormality, if everything is fine, you encourage her to initiate breastfeeding and then observe her for any other thing. Thank you.
We want to discuss topic 2, which is on neonatal resuscitation procedure. And I want to say that it doesn't necessarily follow that you assess the baby before you come to do the resuscitation. When we're doing the assessment, I said that assessment of the baby is not an emergency. So if you're talking about neonatal resuscitation, it means that there is something wrong with the baby. We have to help the baby to breathe. So it is the first thing you do before you do the assessment. Resuscitation involves the institution of different measures directed towards improving the viability of newborn who has difficulty establishing normal physiology of breathing at birth. The reason why we want to carry out resuscitation is that we want to establish and maintain a clear airway. We want to ensure effective circulation. Remember that the respiratory system and the circulatory system have so much in common. When there is any problem with respiration, then circulation is equally affected. We want to correct any acidosis present and to prevent hypothermia, hypoglycemia, and hemorrhage. These are the items you may require depending on your facility. You may need suctioning apparatus with other articles like the bulb syringe. You have mechanical suction, catheters of different sizes. You have infant resuscitation bag, face mask with cushioned rims if possible. You have oral airways, oxygen with flow meter and tubing. You have intubation articles, laryngoscope and endotracheal tube. You have Caesars, starlet Caesars. We have medications like the naloxone, hydrochloride, normal saline ringers, sodium bicarbonate, dextrose saline, and then you also need a radiant warmer. You need a stethoscope, adhesive tape. You need syringes of different sizes, needles, umbilical cord clamp, gloves, and warm, dry towels. And I want to say that for our level, we are just going to have the babies breathe, and we may not go into the intubations and all other things. But in a normal setting, when you set in your trolley, you get all of those things ready, so that in case your baby doesn't respond to the breathing within the first minute, and then you make further attempts, you may need to call for help, and all these articles may be ready, so that the person just comes and then is ready to continue with the procedure. Now we are saying that this baby was born and wasn't able to initiate respiration or sustain the respiration. So at birth we did our Apgar score assessment, realized we had some asphyxia. We assess the Apgar score. After assessing the Apgar score, you place the infant under a warmer and you quickly drive the amniotic fluid. You replace the wet sheet with a dry one. You place the baby on his back with a slightly head down 15-degree tilt and the neck slightly extended. You suction the mouth first and then you suction the nose. Now you give tactile stimulation if infant does not breathe. So when you are even cleaning the baby, you'll be stimulating the baby. You want to do a bag and mask ventilation. You do it when you have apnea, when you have a heart rate less than 100 beats per minute and very low Apgar scores. For the procedure, you dry and keep the baby warm. You place the newborn on his back with head slightly extended. You position the mask on the face. You use the face mask to form a tight seal over the infant's mouth and nose. Now, if you don't form a tight seal, some of the air will be leaking and the air entry will be minimal and the baby may not be responding. You ventilate at a rate of 40 times per minute. If the baby is not responding or not breathing, you reapply the face mask, sometimes just due to false application or mal-application of the face mask. So once you reapply and you start the ventilation, then the baby picks up. Sometimes there may be the need to reposition the head with the hair slightly extended, and then you clear secretions as necessary from the mouth. You open the mouth slightly, and then this time you're going to squeeze the back harder than before and give larger breath. Now we won't talk about chest compressions. I've said that at your level, all you may need to do is to just initiate or get the baby to breathe, and you may not go beyond chest compressions and the endotracheal intubations. For chest compressions, it consists of a rhythmic compression of the sternum that compresses the heart against the spine and increase the intrathoracic pressure and circulate blood to the vital organs, including the lungs. Chest compression must always be accompanied by ventilation to ensure that the circulation blood is well oxygenated. Indications: if you have a heart rate of less than 60 beats after bagging with 100% concentration of oxygen for 15 to 30 seconds, then there is a need to do some chest compression. If you have a heart rate 60 to 80 beats per minute and not increasing after bagging with 100% concentration of oxygen for 15 to 30 seconds, you will need a chest compression. You place 2 fingers on the breastbone, the index and the middle fingers just below the nipples of the baby. You make sure not to press at the very end of the breastbone. You keep your other hand on the infant's forehead, keeping the head tilted back. You press down on the infant's chest so that it compresses about 1/3 to half the depth of the chest. You give 30 chest compressions. Each time, let the chest rise completely. This compression should be fast and hard with no pausing. Count the 30 compressions quickly. Use 3 compressions followed by 1 ventilation for a combined rate of compressions and ventilations of 120 each minute. That is 90 compressions and 30 ventilations each minute. Check the heart rate after 30 seconds. If 60 beats per minute or more, discontinue compressions but continue ventilation until heart rate is more than 100 beats per minute and spontaneous breathing begins. You should know that if cardiac compression fail, endotracheal intubation should be initiated by an expert. In conclusion, neonatal assessment and resuscitation are both crucial medicine interventions immediately after the delivery of a baby to ensure the viability of the newborn. The nurse requires all her senses, vision, hearing, smell, to facilitate the appropriate management of this important period, and the assessment is done only on a stabilized newborn during the early hours of life. Remember, we emphasize that assessment is not as important as the baby establishing breathing or sustaining the breathing. So we always do the resuscitation first, and when baby is more stable, you can proceed to do your assessment. Resuscitation is very crucial to the survival of the newborn who is unstable. After going through this is your assignment. You'll be having a video attachment of resuscitation of the newborn, and then do a further reading on the initial care of the newborn, which includes provision of warmth, nutrition, infection prevention, adaptation to extrauterine life, parent and infant attachment, and also safety of the baby. And this brings us to the end of our session, and these are the references.
This is neonatal resuscitation of the newborn. I'm coming to demonstrate how you initiate breathing if your baby is not breathing after birth. Before you do that, you should make sure that you have your ventilation area ready before every delivery, because you don't know the outcome of your delivery. So I have my ventilation area ready. With that, you should have an ambu bag that is functioning properly, and then you should have your max ready. You have the size 0 and size 1 because you don't know the size of the baby that is coming out. So I have my max ready, and you should make sure that it is functioning properly and it's in good shape. And then you should have your penguin suction. Maybe probably your baby has mucus occluding the orifices, so you need this to suction out any secretions from the mouth and the nostril. And then I have my stethoscope to check my heartbeat when the need comes. Now I have my receiver to receive any secretion that I'll be suctioning from the baby. So this is our baby. We have delivered her, but then she's not breathing properly. So you pick your marks, you position your baby exposing the chest area, and then you pick your marks, you place the marks covering the mouth and the nose, but not the eyes. So you cup the mouth and the nose together, and then you use your index finger and your thumb to maintain a firm seal on the marks, and then use your middle finger to support the chin, and then the other 2 fingers will be supporting the jaw. So you apply your marks properly to maintain a firm seal. So you press your ambu bag gently. You press, breathe, 2, 3. You press, breathe, 2, 3. Our chest is not rising. So you clear the airway, the mouth first, the nose, and then you reposition the head. You reapply your marks to maintain a firm seal. Breathe 2, 3, breathe 2, 3, breathe 2, 3. You can give your chest compression whilst you are giving the ventilation, but now it is debatable. So if I'm doing my ventilation and my chest is rising, I don't need to check to give the chest compress. But in case our baby is still not breathing, you have to call for help. So assuming my chest is not rising, I'll call for help. That my help will come and check the baby's heartbeat for me. So there are 3 evaluation questions you ask during your resuscitation. Is your baby crying? Is the baby breathing? How is the heartbeat or the heart rate of the baby? So I'll call my colleague to come and check the heartbeat whilst I'll continue my ventilation. So I'll call my colleague Ines to check the heartbeat for me. With that, she can either use the stethoscope or use her fingers to check the pulse at the base of the cord. So, Auntie Ines, this is my baby. I've been ventilating for the first minute, but my baby is still not breathing. So I want you to check the heartbeat for me. Whilst I'm still ventilating, she is checking the heartbeat. The heartbeat should be between 100 to 120 beats per minute. So for this baby, my breathing is not coming, my chest is not rising. How is my heartbeat?
112.
Okay, heartbeat is there. So I have to reposition again, reapply my marks, maintain a firm seal. Now I would have to squeeze the bag harder to give a bigger breath. So I'm squeezing. My chest is now rising. You can see that with the rise and fall of the chest. So I continue my ventilation. My chest is rising. I tail it off gently and see if my baby can sustain the breathing herself. So assuming the baby is breathing now, you wait and see if your baby can maintain that breathing. Should you stop the ventilation and then the chest is not rising again, you have to continue your ventilation. But should she continue breathing properly, then you have to continue with your routine care. But assuming my baby is still not breathing, we can attach an oxygen to the ambu bag or give injections, ephedrine, naloxone, and other medications that will be needed. But for this procedure, we would be seeking advanced care because we don't need to give the medications. So I would have to ask my assistants to write referral letter, call the referral centers whilst I'm still ventilating, trying everything possible to maintain my breathing. So we'll quickly call the ambulance, review our emergency plan, and send our baby for advanced care. But in this case, my baby is breathing properly. So the cry has come. I'll quickly dress up my baby. To keep warm, I wear the cap. Change my cord sheets because this one might be swelled during the ventilation. So you do that quickly so that your baby wouldn't get cold. You wrap firmly, but not too tight. Now, we will take the baby to the mother and then explain the findings of everything we have done for the baby. And then we'll give routine care and still monitor for any deviation from normal. So this ends the resuscitation of the newborn. Thank you very much.